Hello, I am Dr. Ahilasamy from Chennai, India. I am going to show a case of how I did endoscopic sinus surgery for a right antro nasal polyp with bulky inferior turbinate and a conga bullosa and a bulky middle turbinate and a very narrow space and not prepared case pre-operatively and a 16-year-old boy taken under general anesthesia in a surgical camp in East Africa. I will be showing how it bleeds very badly when it is not prepared nose preoperatively with steroids. And moreover, when you not have a proper good hypotensive anesthesia. First step is to pack the nasal cavity with a roller gauze soaked in 4% lignocaine and adrenaline or a adrenaline pack. This is on the left side, even though no pathology, I am packing. After repeated packing, still there is no working space. Packs are removed. The antronasal polyp is not very clearly seen. Of course, there is a glimpse of view. I am chopping the inferior turbinate to get oh, some working space. Just medializing the inferior turbinate before chopping the inferior turbinate. Of course, people call it as radical. Without this, I don't have any space, working space, and since the BP is high, you see lot of bleeding. I didn't have even warm saline in the OT because being a surgical camp. Otherwise, a warm saline frequent rinses will take away the blood from the field. When it is bleeding like this, it is very difficult to do even an inferior turbinectomy, and the scope gets fogged frequently. See how badly it is bleeding. So always prepare the cases preoperatively, and you have to do under hypotension or local anesthesia. This is the situation many people face in India and all over the world when they take a unprepared case, that too under general anesthesia without hypertension. I am trying to do the inferior turbinectomy till up to the posterior end. But you can see I am struggling. Frequent suction that even doesn't help. That's a polyp, antronasal polyp, which I am sucking. In the bloody field, you can't clearly appreciate anything. Some resected turbinate, I am taking it off. As piecemeal. That's a polyp. Antronasal polyp, which I am debraiding it off. Of course, I didn't show the CT scan in this starting of the video, and the polyp and the remaining turbinate is being shaven off, and the rest of the bone will be taken separately. That's the bone, and the mucosa surrounding it is being shaved off. It is a 45 minutes surgery, which I have edited to around 18 minutes. Still, it will be a little boring video. Please watch my videos on a bigger screen like laptop or desktop, or pair your mobile to a TV screen and watch it. More blood, dark field, and the rest of the turbinate and the polyp is being shaved off. Because I couldn't do a clear cut inferior turbinectomy in this case because of the bleeding. The field is very dark in spite of Store's endoscope and Store's spice camera because of the bleeding. That's a turbinate bone, which I will take it off. Some irrigation is being done with the syringe by my assisting scrub nurse. Even though it's not warm saline, it is an ordinary saline, flushes to clear the blood. Still, I couldn't yet reach the choana. The nasal part of the antronasal part has been shaved off. I am packing the area for some time with adrenaline 4% lignocaine roller gas to get some more decongestion. Still, I couldn't see the middle meatus because of the bulky middle turbinate. I'm trying to medialize, but since it is a bit of Congo bullosa and very bulky, no working space in the or view of the middle meatus. Trying to visualize the middle meatus couldn't. I am doing the partial middle turbinectomy, taking out the lower half of the middle turbinate. In these cases, this congoplasty or congal crushing doesn't help because we need more working space opposite to the middle meatus. Very narrow nasal cavity and bleeding like a hell. More bleeding has been edited. Still, the posterior part of the middle turbinate is I am resecting, and the resected middle turbinate will be taken out. with a big Maxillary forceps. Literally, I am working in a pool of blood. This is the scenario when many people work or do FES under general anesthesia. That's why many times FES fails. Sucking the blood from the choana and the resected middle turbinate, I have pushed up and I will deliver it with the Maxillary forceps. Every step you can see that there is no clear view or I am struggling at every point. Field is very dark and very bloody. More debridement of the inferior turbinate. And the middle turbinate is taken out. Resected lower half of the middle turbinate is taken out. More bleeding. Still the middle meatus is not into view at all. But one small difficulty when you resect inferior turbinate and middle turbinate, lower half, you may not get the clear identification of the uncinate and entry into the middle meatus or the maxillary sinus. You lose the landmark. So you have to be very careful. That looks like the bulla, what I am sucking, and anterior to that is the uncinate. Lower half of the middle terminal has been resected, inferior turbinate has been resected. Now with my Dr. Ahila's uncinate dissector, I am trying to do an uncinectomy, but I lost the anatomical site where to enter by doing into the maxillary sinus by doing an uncinectomy. The bone looks hard. This is the problem. If you still aggressively do, you may enter into the orbit by breaching the lamina papyracea. So now I have taken a curved sucker. I know the polyp would have widened the middle meatus, maxillary ostia area, middle meatus maxillary ostia area. So I could enter into the maxillary sinus. Then I will start widening around that's the maxillary sinus. I am lifting it off. Now I have entered into the maxillary sinus. That's the maxillary sinus. Then I debride the polyp from that's a polyp inside the maxillary sinus. So some irrigation and debridement, that's a polyp. debriding the polyp from the maxillary sinus. So far, I am working with the 0-degree telescope only. Unless I take the polyp from the maxillary sinus, the polyp will recur and the surgery fails. So after doing the partial middle turbinatomy and inferior turbinatomy and some lower part of the uncinate I have removed, then only I could have a wide opening of the middle meatal androstomy and a working field. Rad 120 blade I am using to take the polyp out. So all the polyp has been removed. This is working with a 70-degree telescope. This is a Rad 120 blade. Of course, we could achieve some remnant polyps being taken out with a coercious antral forceps. That's the antral forceps. Still, there is an attachment of the polyp or an avulsed mucosa, whatever it may be, but still you have to take it out. Some part taken out, rest being debrided out. So some polyp attachment is remaining, that will be taken care with the Rad 120 blade. Before that, again I am using the coercious antral forceps. Finally, the Rad 120 blade is being used to take out the polyp completely. The polyp attachment is being debrided, the Rad 120 blade, and I am using the 70-degree telescope. Now I have switched over to the 0-degree telescope. Bleeding has come down because it is trickling down into the choana. That bone chip from the middle terminal will be taken out. And that's the finishing of the surgery. Thank you for watching. See you in another beautiful video soon. Thank you. Bye bye. Contact me at this address anytime. Bye.